Hi, I'm Amanda Decker. I'm a family nurse practitioner with over 17 years of experience. The last 5 years, I've worked in medical weight management, helping people lose weight and getting healthier, regaining that health that they'd lost. So recently, on January 9th of this year, 2023, the American Academy of Pediatrics published the clinical practice guidelines for the evaluation and treatment of children and adolescents with obesity. It got a lot of attention, well, from everywhere. And it left many shocked with the treatment recommendations. Being a practitioner, but more importantly, being a mother, I am very concerned about the health and future of our next generation. I felt compelled to go and read these clinical guidelines, not only because I treat obesity, but because I am a mom and I have this concern, and kind of weigh in on this topic. So first, let's talk about what is obesity in a pediatric population. So unlike adults, where we use BMI or body mass index to define obesity, if you have that's not used in kids. So if you have kids, you're probably familiar with the growth charts and the percentages, where do they fall in for their height and weight percentage. So for obesity, you get that as well. So for a child to be in the overweight category, they have to be in the 85th percentile. To be in the obese, you have to be in the 95th percentile. What does that look like? Well, it changes as the kid grows and changes because their percentile changes, their height, everything is thrown off. But it sounds like it's pretty basic. So if you're in the, say, 87th percentile, well, that means there are 86% of people, supposedly kids, that are just in your same demographic, age, whatnot, and gender, that fall below you. Personally, I think waiting to the 85th and 95th percentile is a little on the high side. It's a little too late. I think we should really start looking to intervene at 75th percentile. And not that we get really intensive, but that's time to be having those conversations and starting to make small changes before we even get to the being overweight or obese. That's what I do in my adult population. So why don't we do that in our kid populations? As I see an adult starting to get to the upper end of BMI and starting to barely tip over, well, we intervene then. We don't wait until we hit obesity. And there's been this disturbing trend recently, and particularly pertaining to kids, where we're just going to be adjusting the normal range to fit the population that's changing, because what's becoming more normal is being overweight. Well, at some point we have to stop trying to normalize obesity. Now, hear me when I say this. Every human life has worth and has beauty at every size, no matter where they are. But that doesn't translate into health. Obesity is an unhealthy state that will at some point lead to a chronic disease. It may not on day 1 or 2 years in, but it at some point it is going to lead to chronic disease. So right now in America, 1 in 6 children suffers from being overweight. And either 1 in 3 are either obese or overweight. Did that resonate with you? 1 in 3 kids in the US right now suffers from either being overweight or obese. Children with obesity don't escape the chronic conditions that come along with it. So the comorbid conditions that are identified in this clinical guidelines are things like high blood pressure, high cholesterol, type 2 diabetes, asthma, sleep apnea, joint pain. Hold up. 40 years ago, children rarely had these. Rarely did you have a kid with these conditions. When I started practice 17 years ago, rarely did I have a child with hypertension, diabetes, high cholesterol, joint pain. But today, it's an everyday occurrence. So this is an urgent problem. And I totally agree with the American Academy of Pediatrics that it is an urgent problem and needs to be looked at. So I pulled up these clinical practice guidelines, hoping it would be something helpful for my clinical practice. Now, I work in a semi-rural town in Tennessee. So that just know where I'm coming from with that. So I pull up this document and it's 100 pages. So the first time I pull up this document, I shut it right back down because I'm a busy clinician. I work a lot of hours and I'm a mom. I didn't have time to read through 100 pages. Well, so I pulled it back up later. It was like, maybe it's a lot of citations. And it was, but still 73 pages of it is actual documented or content, and there are 801 citations in these clinical guidelines, which clinical guidelines should be highly grounded in research. And so I'm glad they had 801 citations. I'm also glad that it took off a little over 25 pages there for me, but still 73 pages, busy mom, busy clinician, that's hard to kind of get through. So when I did go ahead and take some time and read through this, I found it insanely long with a lot of redundancies. It reads like an academic text rather than a clinical guideline. So other clinical guidelines that I have are like bullet points, and they tell me exactly what to look for, and I can go and look, all right, if I want to focus on treatment right now, I go right here, and I got my bullet points and I can do it. That is not this. This is definitely reading like a textbook, definitely reading like an academic text. Busy practitioners, they're just not going to take time to read that. It's not practical the way it's written. But regardless, let's dive in and see if there's anything that I, the role practitioner, and possibly you can use. So the first big section, it just kind of sets the stage for it, which is good. You have to do that, but it discusses prevalence of obesity, the science of obesity, identifies health inequities, things like racism, weight bias, stigma, and adverse childhood experiences, all that are associated with obesity. That's all fine and good. It is worth mentioning so that we can be reminded to be sensitive to these things as we are treating kids. However, these things were not just in the beginning, not just in one section. They were brought up again and again and again and again. And I get it. It's important. But remember, we're working clinicians here. We need short, practical information that we can use and act on in the minute. So there was a very large section on risk factors. Honestly, there was a lot of writing, and then there was a short table at the end of the section that summed it all up. So I focused on the table because, like I said, I don't have time for that. So I went to the end of the table and read that. And the things in the table were great explanations. And so, but I still, just because we can explain obesity in certain ways, that's not helping me in my clinical practice, which, remember, these are clinical guidelines. So the things that this table talked about was, first, policy factors, things like marketing of unhealthy food to children, under-resourced communities, socioeconomic status, children of immigrants, and food insecurities. So my take home from that was that we as clinicians need to be aware of these so that when we're talking to our patients, we are not suggesting interventions or suggesting things that are unrealistic. And you probably need to write to your representative, and we need to change how we market food to children. That 100% should happen. It didn't technically say anything about marketing or writing your representative, but that's all I can think to do as me, single me. All right, so community factors. Things like school environment, which I'm definitely going to talk about in a minute, proximity to fast food, access to safe physical activity. So my take home from that is you need to know your area as the treating practitioner, know your resources, and know how to refer your kids and make suggestions for your kids so that you're making realistic, recommendations. Family factors. So childhood obesity has to be treated as a family intervention. You cannot expect a kid to change and watch everybody else in the house not change. The kid is part of the family. It has to be treated as a family. And if you don't treat childhood obesity as a family intervention and as a family problem, it's going to fail. It just is. Point blank, it's going to fail. And this document does bring that up, and it says it multiple times, and I applaud it for that. So things that family factors that it identified as issues are parenting feeding style, so how the parents eat, the consumption of sugar-sweetened beverages in the home or anywhere else, portion sizes that the parents allow and the parents eat and the parents serve, snacking behaviors, dining out, eating meals as a family versus everybody eating separately, screen time, sedentary behavior, sleep duration, smoke exposure, psychosocial stress, and adverse childhood experiences. So this section is key to the treatment of obesity, and I agree with it. And I'm going to discuss this more in the end when I give you kind of my suggestions and what I think we need to do. So, but for now, let's keep going. There are individual factors. It brings up genetic type things, epigenetics, prenatal risks, postnatal risks, like breast versus bottle feeding prevention, basically that part we need to be aware of. Now, you need to know that they're a genetic risk and you need to be screening for them. If you come in, the child is sitting in front of you and you identify something that looks like a POMC deficiency or a leptin deficiency or something like that, you need to know that there's genetic things. You also need to know how the child's environment affects their genetics and makes them express in different ways. And you need to be able to educate on how we can prevent some of those epigenetic changes and some of those postnatal things like the breastfeeding versus bottle feeding and antibiotics. We need to be able to educate so we can possibly prevent obesity. So yes, 100% agree on those. The next section is guidance and evaluation to treat. So it talks about the lab that you need to be checking and comorbidities. So when I read this section, I think it could be way more helpful to people who are practicing within pediatrics only. But when I read it as a family practice trained provider, it is basically how I screen and diagnose and test adults. It's the same exact testing. Something I did find interesting is that they said fasting insulin was not recommended as it was highly variable, and it is highly variable. However, I disagree. If you are fasting, whether you're a kid or an adult, then your fasting should fall below a certain level. And if it doesn't, Houston, we got a problem here. We're not as sensitive to insulin and we are eating in such a way that is overstimulating our insulin. So I find fasting insulin insanely useful regardless of the client's age. So, however, say you don't like fasting insulin. Okay, maybe let's recommend something else. Let's recommend a C-peptide. Maybe, that can give us good information and tell us how insulin sensitive we are. But just getting a point glucose and an A1C, we're not getting any closer to the diagnosis of insulin resistance any sooner in order to act sooner. So I love how insulin level is irrelevant for insulin resistance. That it just seems a little off. So the next section, and I printed this one off because I was excited. It's treatment. All right, finally, something I can use. Not so fast. I was very disappointed. I was really hoping for more. I was hoping for something I can use every day in my clinic, day in and day out, something that I can do to make a dent in this childhood obesity problem and help our next generation. Now, it does identify obesity as a chronic disease, which it is, and that we should treat it along the lifetime continuum. It's not something you can treat once and then forget about. It transitions. You start it in childhood and you're treating it into adulthood. Something that I did find interesting that they didn't include that I felt like it should have been if they were going to go into the continuum type thing is there's good evidence out there. There's clinical evidence and scientific evidence that if you help a child remain or achieve a normal weight before puberty, so between the ages of 8 and 12 years of age, then we greatly reduce the risk of that child suffering from adulthood obesity. This wasn't mentioned. And to me, that puts some urgency on things. If we can help our kids in that time window achieve a normal weight, man, we can help them prevent that issue in the future. Not 100%, but it definitely does help. So then there was, in this treatment section, a very large multi-page area about motivational interviewing, blah, 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 blah. Okay. Yes, it is an effective communication style. I use it day in and day out in the clinic. Is it worth mentioning? Yes, it's worth mentioning that it's an effective communication style, but you need a whole class on how to interview this way and carry on a discussion this way. And then you need lots of practice. So mention it in the document, but then let's move on. We need hard practical information. Taking up that much space is not helpful. So first line treatment in obesity, and this is for adults and for kids, but especially in kids, they call it intensive health behavior and lifestyle treatment. So they gave me the initials, thankfully, throughout the rest of the articles, but intensive healthcare behavior and lifestyle treatment. They describe that research shows the more contacts you have with the individual and their family, face-to-face contacts, then the better the outcome. And that care should focus on the family, and that best practice is 26 or more hours of face-to-face contact within 3 to 12 months. So first, I can assure everyone out there that the more contact you have with your client as an obesity provider, the better your outcomes are. I see that with every patient that I work for, the ones I work with and I work for. Um, Everyone that comes in, the more frequently they come in, the more they keep their appointments, the more they contact us through our app, the more they're in communication, the better their outcomes are. So that is truth. And once again, in children, the interventions have to rely on the family. But let's revisit that 26 hours. 26 hours over 3 to 12 months. All right, so most providers just went ahead and put the paper down and said, "Forget it. I can't do this. There's no way I can do that." We barely get 15 to 20 minutes every 3 months if we're lucky. The average provider does. Now, in fairness, the article does point out that this care should come from multiple providers, not a single provider. But unless you live in or at or practice in a large city that is in a large multi-specialty group type thing, that's just not going to happen. It's not going to happen. So this 26 hours in their perfect world should focus on healthy eating and physical activity. However, they state the specific nutritional and exercise content varies widely among all of the studies and is delivered in different combinations. So no one unified approach has demonstrated superiority over another. Thank you so much. That's so helpful. Not helpful. At least tell me the main strategies that you see over and over in the research that I can maybe start working with my clients. And if one doesn't work, well, then I can implement the next one. Not helpful. All right. So physical activity. It's more effective if the child is engaging in the activity. So the intervention needs to be the child engaging in the activity as opposed to just counseling the patient. So this document is clinical practice guidelines. I would so love to go play with the kids that I treat. And maybe I'll start doing that at some point. I have started classes with my adults and things, and maybe I should start doing that with my kids, if that's a more effective intervention. But all I got in the clinic setting is counseling. That's all I got. So the take home that I got from the physical activity section is encourage it and know your community resources and refer to those community resources. So going back to the nutrition side of things, when it comes to nutrition, the research shows that interventions are also more effective when kids are directly involved in the meal prep and the tasting compared to nutritional education. So once again, this is great for large groups that maybe have classes that kids can go and cook and entertain, but most of us here in the US, most practicing providers, we don't have that. But let's keep going. So let's go back to that specific content, and the treatment intervention varies. However, they did mention in one little blurb line that a reduced glycemic load can be helpful, and also meal replacements. So one, I am all for reduced glycemic load. That is something that I can work with, I can work towards, I can implement that in the clinic. Now let me talk about meal replacements for a minute. I don't really like meal replacements. Every now and then, okay, have a protein shake, have something and use it for when you're busy, but they're not helpful long-term in a chronic condition. A kid is not going to eat Nutrisystem packaged foods for the rest of their lives. Adults, when they go on these programs, only eat them for a short time before they give up and quit them. So why? Okay, it does not teach anyone how to eat and how to live in a real world. It makes them also dependent on processed food. It's too short-sighted, and it feeds the addiction side of the brain because it's still processed food. They mentioned also, so I'm moving on past that, they mentioned that studies that are out there that had successful interventions also focused on sleep, screen time, and guidance on the fact that there's not a quick fix. It's a slow one step at a time. And so yes, 100%, we need to be protecting our sleep. We need to be limiting our kids' screen time, and we need to be giving guidance that this is not going to fix itself tomorrow. It is something we have to keep working on every day. So to sum up their recommendations for treatment of the behavior side of things, it needs to be high intensity with 26 or more hours based on behavior change, family focused. Oh, and we also need to teach the parents self-management skills and role modeling. So yes, that's important. And now I feel like I need to hire a psychiatrist and a social worker to come in for parenting classes after this. This is all fine and great in the ideal world, in a large academic setting that has all kinds of specialties, but that's not the majority of us in the country. But so I wouldn't, just when I'm feeling hopeless of, okay, there's absolutely, I can't do any of this, I flipped the page and they did say, all right, when the ideal is not possible. Okay, thank you. You're speaking my language now. When the ideal is not possible because healthcare systems and payment systems limit time to resources and limit time to primary care, then you should still try to intervene. Okay, thanks. Tell me how. Here we go. They say that, even the little minutes families can benefit from, and they want you to still refer to other community resources like an RD and exercise specialist. That would be great, but most of us, especially in the rural area, the PCP is it. That's all a patient's got. That's all they have. There might be some school programs. There might be, a gym somewhere that offers something, but the PCP is the RD. The PCP is the prescriber, the diagnoser, the encourager, the coach, the everything from start to finish. We're it. So that's what we need these clinical guidelines to go over. So in this section, in the non-ideal world, when the PCP is the main intervener, most successful interventions from the current research describe nutrition counseling without a structured diet. So what this tells me is that they're kind of teaching them by the government guidelines, but they didn't really say that. They did point out that in some of the studies, there was a structured diet. In one, there was a study that was low carb, and there was another one that focused on just cutting sugar-sweetened beverages. And in both of those, the children who had the intervention of either low carb or reduction in the beverages saw better than the control. There were 2 studies also that focused on decreasing calories, but they also increased exercise and did behavior change at the same time. They showed better than controls. And there were also 2 studies that focused on eating low glycemic load diets, and they also showed better than the controlled. So my take home on what they say that I should do for diets, as far as which one in the research does the best, is just do something. It doesn't matter what you do, just do something, but reduce glycemic load, which is kind of also low carb, making 4 studies showing that that is effective, could be a good intervention too. So that was my take home. They did list some strategies, and I think this one could potentially be helpful and give us information that we can use in the clinic as providers. So there are 4 recommended behavior strategies were to decrease sugar-sweetened beverages. This includes soda, sports drinks, and juice, because people think that Gatorade is a nutritional supplement, and it's not. So decreasing sugar-sweetened beverages. Choose the My Plate, which is the government's idea of how we should eat, which is low sugar, low fat, balanced protein and carb. Encouraging 60 minutes of physical activity a day, and decreasing sedentary behavior. So if you could encourage your patient to do those 4 dietary strategies, they would lose weight. And I agree, if they did them successfully, they are going to lose some weight, especially because kids have better metabolisms than adults and can respond quicker. They did give me 5 common strategies to implement. Oddly enough, the first one, which I think should have been included in the behavior strategies, was avoiding skipping breakfast. Now in adults, I encourage a lot of intermittent fasting, and in kids, I don't really encourage intermittent fasting. One, their metabolisms are so much higher than adults, and they're hopefully burning more energy than we are sitting at desk working. So I do think that they need to eat breakfast and lunch and dinner. So that, I think that's an important one. And in my kids that I see that skip breakfast, they almost always overeat at other meals later down the road. So I agree with that one. There's something called the traffic light diet. So it's, thinking about a traffic light, the red, yellow, green, and you put foods into different categories. Who decides which foods should go into that category? That could, change the effectiveness of that approach. There's an approach called the 5-2-1-0. So 5-2-1-0 is encouraging the kid to eat 5 fruit or vegetables in a day, to have at least 2 hours or less of, only have 2 hours or less of screen time, 1 hour of physical activity, and 0 sugar-sweetened beverages. So that was the 5-2-1-0. They also recommended the use, so basic physical activity, using screens, so some of your screen time, for physical activity. So think Xer games. Yeah. And then getting appropriate amount of sleeps. So having an appropriate amount of sleep and using your screen time, I think those are two pretty important ones. The next section is pharmacotherapy. And this is where tons of the uproar came about these guidelines. So let's kind of dive in a little bit. So it's recommended, pharmacotherapy is recommended to children with obesity who are 12 years of age or older, possibly sooner, possibly at 8 down the road, but right now 12 and older, who are not doing well with their intensive lifestyle behavior modifications. The drugs that they go through are pretty much the same drugs that we use in adults. So there's metformin, and the document recommends using up to the full adult amount of metformin. There were major reported GI issues, which we see that in adult as well, which kind of like, all right, I'm going to give a kid who's suffering with obesity and probably getting picked on, something's going to cause major GI issues. I'm a little worried. But they recommend using it, especially if the kid has prediabetes, PCOS, and also to blunt the gain of psychoactive medicines. So medicines that might treat anxiety and depression and things like that, or bipolar or mood disorders, they have the side effect of weight gain, and metformin can block that in some kids. The next drug is orlistat. And orlistat works by blocking fat. So it blocks fat so that it just passes on through the intestines. I hate this drug for everybody. I just don't think it's a good idea. But the major side effects are stinky stool, fecal urgency. So you gotta go, and you gotta go right now, and it's not pee, it's poo, and flatulence. So you're having lots of gas. What a great idea to give a kid who's obese and already subject to weight bias and stigma and traumatic events, a drug that's going to get them picked on a whole lot more when they try to go to school. I don't think this is a good idea. Then there's the GLP-1 drugs, and these are the rage everywhere, it seems like right now, and I'm going to do a separate video just on GLP-1s and if they're pros, cons, should you do them or not. But these are drugs like liraglutide and semaglutide. They are approved for 12 and up. There's an older one, exenatide, that's approved for age 8 and up. These work on the gut and the appetite hormones that come from the gut that go to the brain that tell you you're full, stop eating. They also slow motility of things, slow motility of food through the intestines so that you can feel full longer. I have concerns about starting these very young. Are there going to be effects on a kid that's still growing? You know, the kid whose bone is still growing, because we don't recommend in pregnancy because there could be problems with bone formation. Well, these kids are actively still growing, and we're going to give them a drug that there could be an issue with. It's also contraindicated in pregnancy, and this is kind of a risky group for risky sexual behaviors and early pregnancies anyway. So now we're contraindicating in pregnancy. And then there's also the known fact that these drugs cause fat growth. So while they shrink the growth of fat cells, they encourage the growth of new fat cells. And if we start doing that when a kid is 12, what's that going to look like when that kid reaches 30? I know, I have concerns. Phentermine, it's approved for age 6 and up for a 3-month period. This is a long-term condition, and we're going to throw a 3-month drug at it. It makes a lot of sense. And I know that this is used in adults all the time for long-term use. And, you know, it's also used in other drugs long-term. But I do have concerns about it creating yo-yo dieting, going on and off the drug. I also see a lot of mood issues with this drug, especially at the dose of like 37.5 milligrams. But I see a lot of anger, agitation, problems with sleep, things like that. I don't know if that's a good idea in kids. I just really don't. So Qsymia. Qsymia is a mixture of phentermine that we just talked about and topiramate, which is a migraine headache medicine. And it's approved for age 12 and up if they have documented failure of lifestyle interventions. My concerns are the same, plus some more, because there's side effects of topiramate can make you kind of sleepy, foggy headedness, which is not kind of good in a kid that's trying to learn. So weight loss surgery is also recommended as an intervention in kids as early as age 12. My main concern, so the main surgery they recommend is the traditional Roux-en-Y surgery, but my main concern is malnutrition while a kid is still growing. They're not necessarily super reliable about taking medicines, taking care of themselves to start with, and then we're going to restrict their intake of nutrients. What's that going to do to their bones and things down the road? We already know that the adults in this population have risk of osteoporosis. We start bumping this backwards. What's that going to do? Also with surgery, we see that there's an increased risk of addiction, sexual addiction, alcohol addiction, drug addiction. Do you have this high risk group already, kids who are not sure and have a lot of drama, trauma, whatever going on, and they're already at risk for trying drugs and alcohol at a young age, and then we're going to give them a surgery that's going to, we know it's going to also increase that risk. Yeah, that concerns me. We also see in the adult population an increased risk of suicide after. And possibly both these drugs and alcohol after weight loss surgery and suicide could be related back to food addiction and dependency. You remove that person's coping mechanism. They no longer can eat that processed food. They no longer can have those sugar sweetened beverages, those things that they coped with. You removed their best friend basically without teaching them alternatives on how to cope and deal and whatnot. I don't know that that's a good idea. We're seeing the rise of teen suicide. And so I think this is something we need to be very careful with. Now, do I think that meds and surgeries have no place in childhood obesity and should not be used? First of all, let me just say, I hate that we are at this point where we're even having to have this conversation. However, I have several pediatric clients that I worked with for over 2 years, and the families were not getting on board. They were kind of bringing them to their appointments, supporting them, but they were not changing the home environment, just expecting the kid to change themselves. Not great situations. But anyways, these kids continued to gain weight. And so I've put kids on Saxenda before, or liraglutide. And at first, they lost weight. For about the first 6 months, they lost weight. They're feeling good about themselves. But then they started to gain weight. And one of those unfortunate kids is now up to 350 pounds at the age of 15. No, almost 16. So I reluctantly referred for bariatric surgery because I don't know what else to do. Didn't know what else to do. I've done all of the interventions that I could do other than me taking the kid home with me, and I've got nothing else. And so I referred for bariatric surgery, but no one in my state took the kid's insurance for bariatric surgery. So here we are, still trying. I'm still going to see him. We're still going to try to intervene and do the best we can. But overall, my general thoughts on medicines and surgery in pediatric obesity is that we continue to try to medicate and cut our way out of obesity without addressing the root cause. These can be tools, but we as a society lean on them as solutions. And that just leads to a further disservice of our kids that are already in trouble. So what do? Parents have to step up. We have to step up. Parents have to be the role model that our kids need. If you as a parent have an issue with obesity, then you need to get help and you need to do the work that it takes. You have to make the hard choices and then you deal with the frustrations that come. The situation stinks. It stinks, but it's our job as parents to control our kids' physical and food environment, to protect them emotionally and teach them skills from a young age on how to deal with stress. Our kids will protest, and it will make life temporarily miserable when you change their processed food environment. I wish I had never given my kids that first cereal puff or Cheeto, but I did, and I had to deal with their lamentations when we removed them from their diet. So, parents, it's on us. We got it. We got one chance to get our kids healthy before they're out of our home. We need to remove all sugar drinks. We need to remove soda, Gatorade, Powerade. They're all not necessary. There's nothing necessary about those drinks. Juices, they need to go. We start giving our kids these things at a young age, and we're just creating a sugar dependency from as soon as they're weaned. They're not needed for life. They need to be removed from our home, and they need to be removed from our school. We got to cut the frequent snacking. Teach your children to eat satiating meals that are protein forward, protein driven. Snacking's a relatively new thing. It's been encouraged by processed food companies, and honestly, it's not necessarily. If you eat a solid meal that's good in protein, a snack is not necessary. As Robert Sywes says, it's an emotional need. We can make it through a 1-hour sports practice or a game without a snack, unless you have some other health issue. We can also make it through a school day without a snack. My daughter eats lunch at 11 and leaves at 3. She can make it that long without a snack. We have to cut electronics at mealtimes. Electronics should be put away. We focus on the food so that we can recognize when we are hungry and when we're full. So that has to go away. We need to eat at home more than we eat out. Eating out is part of life now. I realize it. I'm not saying don't do it, but by and large, you should eat at home more than you eat out. Be active as a family. Don't just tell your kid to go outside and play. Go play with your kid. Go send all the siblings out. Play family games. Go play soccer, whatnot. Go to the park. Go for a hike. Do it as a family. This is a family intervention. It is not a kid intervention. When the family gets healthier, the kid gets healthier. Build in rest time. If your family's schedule is too full, you have to make some hard choices of what to cut so that your family can rest, so that your kids can rest. And that may mean that they don't participate in 5 different sports at one time. It may mean that you don't get to do everything you want to do as a parent because you have to be there for your kid to make sure they can rest. It is what it is. It's our job. We also need to set bedtimes and set routines. The body thrives on routines, and kids need more sleep than what we're giving them. So we need to get them more sleep. Limit screen time, that 2 hours a day. I agree, not more than 2 hours a day. And it'd be awesome if some of those could be with extra games, the things that you move around, that kind of thing. It is not our TVs and our iPads and our cell phones' job to raise our kid. It's our job. It's my job. It's my job to raise my kid and entertain my kid and make sure that he has what he needs and she has what she needs. So limit that exposure. Pack your kids' lunch for school. As of right now, we can't change school lunches. They are controlled by the U.S. Dietary Guidelines, and the guidelines have just made us sicker. The average school lunch has between 50 and 100 grams of carbohydrates. That's 20 teaspoons of sugar in the blood when you consume it and break it down. I've looked at some of the breakfasts my kids were offered at school, and they were upwards of 150 carbs or 30 teaspoons of sugar and very little protein. And then we wonder why kids can't sit still at school. Pack your lunch for your kid. Send them there. Don't put lunch money on their account, and instruct them they're not to buy things from the lunch. They eat what they're given, that kind of thing. We have to also demand change in our school. We should not be offering candy and food as a reward. That is just furthering food addiction and moving us in the wrong way. Kids love eating lunch with their teacher or having a buddy that they get to sit by on a special day. My daughter loves stickers and erasers and all kinds of stuff like that, or free time to draw and color. Rewards don't need to be sugar or food. Stop selling cookies, candies, and ice creams and chips after lunch. No, one single one of those is not going to make that kid obese. But over and over again, one of those kids, I put on semaglutide, and one of those kids, or actually liraglutide, put on liraglutide, and the one I recommended to bariatric weight loss surgery, I had to call his school cafeteria because he was buying 3 or more cookies a day after school because they were options, and his dad had money on his lunch card. Now, his dad realized, I have to keep up with what my kid's buying. But if it's there, the kids are going to get it. They're going to eat it. They're going to find a way. So it needs to stop being there. It doesn't need to be there. We also need to remove all vending machines from school unless they are just containing water only. Everything else is not needed. We need to stop introducing our kids to processed foods so early. Have you seen the videos of the kids who are like the little babies that they're given ice cream and they're eating it like crazy? It's not cute. It's not funny. It's the start of sugar addiction. It's the start of that kid's lifelong battle with trying to give that up. That we have to stop exposing our kids to sugar and processed foods at young ages. Mental illness is on the rise in all age groups, but especially in kids. We have to figure out as a society and as parents how to make life simple again for our kids. We have to figure out how to remove stressors. We have to figure out how to foster their emotional growth, and we need to teach them social skills from a very young age. Many kids are given way too much responsibility too soon. They're given too much free rein to see adult content too soon. Again, we as parents have to make the hard choices. We have to protect our kids. We don't have a choice. You know, if your kid is exposed to sex on TV at a young age, they're more likely to engage in high-risk sexual behaviors earlier. If they're exposed to drug and alcohol use on TV, they're more likely to do those things earlier. So we have to make our hard choices, and we have to protect our kids. Will this fix it? Is this the answer? Are those things, those like 12, 13 things I listed, is that the answer? No, but it's a start. It's a start. It will not reverse all obesity. It will not prevent all emotional trauma or comorbidities, but it's a start. So were these guidelines, these 73 pages of information and 801 references, were they helpful to me as a solo rule clinician? Not really. They didn't really give me much to work on. But in fairness, there are multi-specialty centers out there that they may be more helpful for. You know, maybe like Vanderbilt, which is an hour and a half down the road for me. Maybe it'd be helpful for them in their obesity care, where they have an RD and cooking classes and psych and whatnot. But my patients can't get to Vanderbilt. Yeah, they can get to Vanderbilt once. Can they get there for 26 hours over 3 months? No, that's not possible. It's just not possible. So guidelines possibly helpful for groups, but not for me. There was some good information in there. There really was some good information in there, but these don't really move the needle in my opinion. So there's my opinion on those pediatric guidelines, and hopefully we'll get some bullet point, more easy to use information in the future. Thanks for listening.